Hello, welcome to the latest edition of IESE Economics on LinkedIn Live. We've started this series to provide you with fresh insights on economics and finance from IESE professors. The global economic situation is more complex than ever, and we are here to help you understand it. Today, I'll be talking about healthcare. The COVID-19 pandemic highlighted to all of us the importance of well-functioning healthcare systems. The pandemic has ended, but global healthcare systems continue to be in a state of transformation. Today, I'll explain how we can do better managing healthcare for ourselves and for the future generations. Please feel free to include any questions you have in the chat and I'll answer them at the end. So now let's go to the healthcare systems in transformation. What we know as economists is that when we have at least two of the following four situations, a market is very likely to be disrupted. The first situation is that this market is huge and suffers from strong financial pressures. The second one is that we have patients or citizens that have different needs that the system is not satisfying. Third condition, we have inefficiencies. And fourth condition, we have disruptive business models with new players. The four of them actually take place in healthcare. So let me start first by mentioning a little bit what happens with this huge healthcare market. Advanced economies are now spending about 10% of our GDP in healthcare. And there's something that we know, that is that as one country becomes richer, it spends a larger proportion of its income in healthcare. So it's not only that you spend 10% of something bigger, but that you spend a larger proportion of this. Hence, it's a huge, very promising market. A market that is under lots of financial pressures. So here we have the first condition that we were talking about. Let me highlight some of these financial pressures that our healthcare systems are facing right now. The first one that we could take into account is the fact that the IMF and other agencies have already projected a lower GDP growth for the next 5 years compared to the one that we had in the previous decades. So the fact that the GDP growth is smaller means that the needs that we need to finance actually will find less income to do so. The other financial pressure worth highlighting, and you are going to see a graph here about that, is the current situation of high and persistent inflation. In this graph, you can see two lines. You can see the top line, which is the total inflation. This is actually decreasing. This is the inflation for the Eurozone. But actually, the second line shows what we call the core inflation, the one that does not include factors such as food or energy. And here we can see that it's very persistent. In front of such a persistent core inflation, central banks are reacting globally by increasing interest rates. And these higher interest rates, what they mean is that it's going to be harder, more expensive to finance any financing need that we can have. This is taking place in a context with very high public debt. If you look at the figures that we have right now, you can see how global public debt is actually historically very high. The total public debt is 93.3% of the GDP, and in advanced economies, 112.4%. That's a lot. And actually, to pay for this public debt, the resources come from our taxes from the private sector, private families, private companies, and hence this public sector debt is just one part of the story. If to this public sector we add private debt, we will see that the total we need to finance is much higher. For instance, in Spain, the public debt is 115% of the GDP, and if to this we add the private debt, we would be up to almost 250% of the GDP. To this total debt, we need to add what we call unfunded liabilities. So you can see in this graph what I mean with this. Unfunded liabilities are promises that they've made to all of us. We expect to be taken care of when we are growing older. We expect to receive some pensions, and they are liabilities because it's not debt yet, it's just promises. And they are unfunded because most of the source of financing, it's not some money that I've put aside with my name, but actually it's going to be paid by our children. You can see here, for example, that countries like Germany have 350% of the GDP in unfunded liabilities, or countries like Spain as well have also very high financial liability, unfunded liabilities. So this is something that we need to take into account in this context. And finally, the last financial pressure that I wanted to mention to all of you that we need to take into account is the fact that we are now in a world that needs to finance very many urgent and important structural transformations, such as the green transition that will require lots of resources, or the digital transition. Hence, when we are thinking about healthcare, we see that this is somehow competing with other things that need financing that are also very important for our systems. So this would be the first condition that we set when we talk about systems that are likely to be disruptive, the fact that it's a huge market with very strong financial pressures. The second one has to do with the needs of the patient changing. Here we can take into account what's happening globally. The world is aging, particularly Europe and also Asia, like China, for example, is aging very quickly. And these older patients actually have very different needs. So we have data from IESE, the Catalan Health Evaluation Agency, that shows that in the next 40 years, the amount of patients with complex chronic conditions in the Catalan area is gonna double. These patients are also different in other dimensions. For example, these patients, we are used to convenience. We want care 24/7. We want it right here, right now. So our expectations from the system have also changed. And the system, it's exactly the same. So it's becoming obsolete in serving our needs. The third thing that we said was important is inefficiencies. And when we look at our healthcare systems, we have different measures of inefficiencies. But for example, we have one information from the Institute of Medicine in the US that estimated in a document called Better Care at Lower Cost that 30% of the money that the US was devoting to healthcare was not translating into better health. A similar type of study in the OECD countries was looking at how much money different countries would be saving in 7 different hospital interventions if these countries were doing like the best hospital. The best hospital is not the cheapest one. It's the one that has the best results. And the outcome was very similar. 30% of potential savings if all the hospitals were doing like the best hospital out there. And finally, the fourth characteristics that we said was that there are new players with different disruptive business models. We have Amazon entering into healthcare, we have Google entering into healthcare. Who knows where this disruption is going to come from? But what we know for sure is that when we talk about healthcare, the future is about value-based healthcare. In this context where we have lots of different financial needs pulling in different directions, value-based healthcare, it's the solution. Nothing is going to be financed, no transformation is going to be possible if it does not show that it's bringing a lot of value into the table. And in particular, I've been doing some research on this context, focusing on the AAA. We should be trying to aim at 3 things at the same time that are self-fulfilling. So let's look at them here. First one, better health for the population. That's prevention, basically. If our population is healthier, on the one hand, it will continue working, hence contributing to the system. And second, it's going to be less sick, and hence also will be using the system less. The second aim out of these 3, it's better care. Once I become a patient, I need the right care at the right time, at the right place. With this, I will be reducing complications, I will be reducing readmissions in 30 days, and I will be making the system have lower costs for the treatment of the patient. So we should not just be looking at lower costs, we should be achieving them just because we do things better. And that's the purpose of the AAA. Now, how can we get there? And I will tell you about 6 steps we've been working on to take us to this triple aim objective. The first one, obviously, is to measure things. We need to look at the data that we have in healthcare and be transparent about it. We need to share it. If we don't know what we are doing badly, we cannot improve it. If we don't share it with others, we don't know from whom we can learn. So the first thing is to have this data, and actually healthcare, it's the sector that has the fastest growing amount of data right now. We have more than 1 billion sensors already in place. And in Europe, we are working in building up this European health data space that aims at sharing anonymously, obviously, with all the right guarantees for the patients, all this data that we have been building up in Europe. Now, the interesting thing about data for health for the triple aim objective is that only 20% of our data comes from the traditional healthcare system, hence hospitals, primary care, and so on. The remaining 80% comes from non-traditional systems. We are not used to look at this data when talking about healthcare, and yet it's crucial to make the difference. So 30% has to do with behaviors and habits. If I'm talking about prevention, this data, it's fundamental. I need to know whether I'm eating well, whether my friends are a good example for me, because if I'm a friend of somebody of a group that never runs, it's going to be harder for me to run. If they never exercise, I might exercise less. So it's important to know the behavior and habits, not only mine, but also of my peers. 10% is the physical environment. Do I live in a big city or in a rural environment? How's the pollution in my area? And finally, 40% are socioeconomic characteristics. Do I live on my own, which is my income level, my studies, the ones of my family, and so on. So first thing, we need data. Second thing, we need to identify success stories and know why they are successful. Once I know something is working, I need to disentangle it and study all the characteristics so I can learn from this success story. The third one, it's again patient-centric. In healthcare, we talk about that all the time. We always say we should focus on the patient. Yes, we should, and yet we don't do that. What do patients want? Patients want to be treated from home, not from hospitals most of the time, if you let them choose. Are we doing anything about that? Patients are very different. Some patients are very engaged. They love to be part of their treatment. They want to know about every detail about their cancer or of their chronic disease. Some don't want to hear about that. They are much less activated. Clearly, what works for one cannot work for the other, and we need to take that into account. The other thing that we need to make this triple aim possible is to focus on public-private partnerships. We need to have so many things changing, so many pieces coming together that none of the two sectors can do it on its own. And actually, not only this, what we've learned from COVID is that we get the better results when we leverage each other. In this context of strong financial pressures, different disruptive models, we need this collaboration. We should foster it and leverage it. And finally, 2 more things to take into account. Integrated care. We need to include all the players in the system. If I'm talking about prevention, I need to think about the workplace. I need to think about schools. And definitely, I also need to think about social care. When I talk about chronic conditions, it's not the same that I have one patient with some complex chronic disease living with his healthy partner than the same exact patient living alone. So the social context is going to be important. The fact that I can opt into social care is going to be very important. Can I integrate social care, mental care, primary care? So this integrated care, it's the solution to all these triple aim. And finally, the incentives. We say, wow, care doesn't integrate. Well, are we putting the right incentives for this to happen? Things are harder to happen if the incentives actually either are not there, or in some cases they even go in the opposite direction. So I was talking about an integrated care model that we have developed that helps us, that has been extremely successful, and it's organized around 4 pillars. This is an integrated model for social care, primary care, and emergency care in the hospitals. Why? Because these are the entry points for a patient. So basically, when I'm a patient, I can choose to enter into the system using the primary care access or the emergency care access. And of course, another way in which I can receive care from the system is social care. So in this model that has actually been implemented in some areas in Catalonia, where we have, it's the center being the patient, what I was talking about before in the triple aim. How is the patient-centric here? Well, this is a model for very complex chronic patients. So what this model does is to organize together the patient, the primary care doctor, and the family, an individual intervention plan. What will happen to me in every situation? Whom should I call if something happens? Should I go to the emergency room, to the social care, or should I call my primary care emergency center, for example? This is all organized. Something else is taken into account here. Look, if I have my third resuscitation, do I want a fourth or not? Do I want, in case I'm very sick, to be taken to the hospital, or do I want to be taken home? All this is discussed with the patient, the hospital, the primary care doctor, and the families. Surrounding this, we have 3 additional pieces that are key for this success. The first one is the stratification of the population. Look, this is not for everybody, obviously. This is just for these patients who can benefit the most of this type of system. So the first thing that the system does is to look at your characteristics and label you. Yes, you are a complex chronic patient that can access to this individual plan, okay? And that's put into a red flag every time anybody sees my clinical record. The second component is precisely this one. These share electronic clinical records. Remember that I was talking about data as being one key aspect of this triple aim? Here comes the data. Everybody who sees the patient will add the information in the system, and every social worker, primary care doctor, specialist, emergency room doctor that sees this patient will also have this information. And finally, a local agreement. And again, remember that I said as a key component, we need to identify what works and understand why. Here comes the why. So we might have something that works perfectly fine in a city that will not work in a different context, maybe in a local area. It's not the same solution that we can give in a local area when we have long-term care, for example, than in a place where we don't have it. And all this needs to be taken into account. So what this local agreement does, and I find it unique in the world, I don't know about any other case where this is done, and I think it's very smart, is that once we agree on the main objective, which is to get the best possible health for these complex chronic patients, the local healthcare providers, public and private, come together to decide how will they organize themselves to satisfy the needs of these patients. The resulting outcomes of this are amazing. The areas in Catalonia who went for this pilot and who implemented that got great results, reducing by 30% the readmissions after 30 days, which is, as you know, a very good indicator of healthcare quality. And they also had very good results in other measures of quality for the chronic care patients. And I think that with this, for those who could hear me well for the second time and those that could not hear me so well for the first time, I hope that this clarifies, and I'm looking for your questions or comments if you have any. And I actually was answering one before, so I don't know if you had the chance of hearing that well, so I will go back to this one as well. I had one question that said that to improve healthcare, what it's better, government-led reforms or actions by the private sector? And I think that it's not either or, it's complementary. Public-private partnerships, that's what we need. And what we need from the public sector and the private sector is to leverage each other. I like to have, universal coverage of healthcare. Data on this shows that it's actually working, but financing healthcare publicly does not mean public provision. There are many ways in which this publicly financed healthcare can be provided. Another thing that it's important is to take into account that, our healthcare doctors, our healthcare nurses, our healthcare companies can be anywhere in the world. So we just need to create an environment that attracts and retains this talent. Here I'm reading, what competencies will executives in the healthcare sector need in the future? That's a very interesting one because, as we've said, this sector is changing a lot and it's getting into constant transformation. So what will be needed? First, I would say this concept of really taking into account the patient pathway. Look, patient is just not, a visit in the hospital. It's all the things that are happening to the patient throughout the management of his or her disease. And that's where the solution comes from. These managers of healthcare for the future will need first to identify these needs that the patient has. Look at which of these needs have not been satisfied, have not been answered by the current system, and then that's where the opportunities are. So which are the needs that people have? What is not being done by the system? What can I do to really fill this gap? Because that's what these disruptive alternative healthcare models will do. They will identify this need for convenience, they will identify this need for prevention, and they'll find a way. And that's, I think, crucial. Is there a country whose healthcare system is a model to follow? Actually, my first answer is no. So let me tell you what we found when I was doing my thesis. We had a paper with my advisor comparing different advanced economies countries. One was Spain, the UK, Canada, and the US. And we were looking at which country was actually offering better healthcare to their patients. And the final conclusion that we got was that actually you get what you pay for. Let me put it into this context, okay? So in the US, they were paying a lot for the latest technology, and that's what you got. Technology-intensive type of treatments. The US was doing very well for this type of treatments. It had great outcomes in this type of patients, but Spain actually was one out of the 4 countries that was having better results in chronic care, in diabetes management, for example. Why? Because our system in Spain is much more integrated. So it's hard to say. I don't think any system is perfect. We can look at which one gets better outcomes at the lower cost, but at the end, it might be a choice. I might prefer to have, a little bit more of a spending and, some better outcomes as well. So that's not so clear. Some countries are better in one thing, some are better in others. Does the trend towards sustainability impact the healthcare sector? That's an interesting question as well, because I think, yes, it does, but in many different ways. One way in which it impacts, and we've mentioned that at the beginning, is that we need all these scarce resources that now, with high interest rates, are more difficult to acquire, right? More expensive. We need all these resources for so many very important things. One of them is the sustainability transition. We need that. Another one is to transform our healthcare system. So one way in which sustainability and healthcare are intertwined is just because both need all this financing. But then there are many more ways. So if you think about the global value chain, most of the products in healthcare have been produced in different countries as well. Okay, and this is something that we need to take into account. And when we talk about sustainability, we mean so much more than green, right? We mean sustainable model that has access for everybody. And thank you. So that's what I wanted to say. But I know that because we had to repeat some of these, I don't really want to take that much time from you. So thank you very much for joining us. And I hope I've given you some of the new insights into the state of the global healthcare. And as you know, IESE Economics is an ongoing monthly series. And you'll be able to find out about the next session on this LinkedIn channel very soon with one of my colleagues. Thank you.